Thank you for having me today. Lovely to be here. Good to meet you all. I'm Sarah. I'm a health psychologist and research fellow in the Health Protection Research Unit in Behavioural Science and Evaluation at the University of Bristol. And I'm currently co-leading this project that aims to, I'm going to talk about the aims in a minute, but this is the project is HIV testing and prevention in general practice, a person-based approach. So the UK government has set this goal of ending new HIV infections in England by 2030. So general practice, so primary care has an essential role in achieving this in two main ways. So firstly, through increasing HIV testing, and the second way it can support this goal is through supporting and facilitating access to PrEP, which is an anti-HIV medication used by people who are HIV negative to reduce the risk of them actually acquiring HIV. So people who are unaware that they have HIV often visit the GP several times, sometimes with symptoms, but sometimes healthcare professionals can miss HIV testing opportunities. So this means that people might only be diagnosed once they've become seriously ill and are at a greater risk of passing the virus on to other people. So it's really important to mention that people who are on an effective treatment with an undetectable level of the virus can't actually pass it to others. So at the moment, the UK guidance recommends HIV testing, or somebody is offered a HIV test when they have symptoms of HIV, when they're at a really high risk of acquiring HIV, or if they live in an area with high numbers of people who have got HIV and have a blood test for any other reason. But we know that this isn't as easy as it sounds, and healthcare providers can face a number of challenges to offering a HIV test. And I'm going to talk a little bit about some of those barriers in a second. So as I said, PrEP is an anti-HIV medication. It's used by people who don't currently have HIV, and it's the goal is to reduce the risk of actually acquiring HIV. It's very effective. It's freely available from sexual health clinics, but there are a lot of people who could potentially benefit from PrEP and they're not actually accessing it, either because they don't know about it or because they don't want to engage with sexual health services. So there is a role for GPs, or potentially a role for GPs in supporting access to PrEP so that more people can access it and benefit. So the aim of this project is to develop, to work with healthcare providers to develop a new approach to help general practice staff deliver more HIV tests and support more people to access PrEP. And to do this, what we did was we used an approach called the person-based approach. So this study had three main parts. So what we did is we looked at some of the literature that other researchers have done and written to find out what challenges exist in relation to HIV testing and access to PrEP through primary care. We talked to a lot of GPs and other healthcare professionals that work in primary care and other stakeholders. So we talked to a lot of commissioners and other people who work in sexual health services. And these interviews really helped us understand some of the attitudes that general practitioners have towards increasing HIV testing. And they also highlighted what some of the challenges might be. And then we used what people told us to come up with some ideas about what might actually help GPs test more patients and support more people to access PrEP. And then we did lots and lots of focus groups with other healthcare providers and members of the public to talk about what people thought about our ideas. So the interviews and the literature review reveals lots of barriers to testing and supporting access to PrEP. So with person-based approach, we always start by thinking about the context within which the intervention is to be introduced and think about those contextual issues that are likely to influence whether or not people can actually deliver the intervention as we recommend. So in this case, the context is that general practice is very stretched. It has people working in general practice have very little time. It's chronically under-resourced. And people really, really struggle to do anything new over and above what they're already being asked to do. And the context also is that HIV cases are actually quite low, even in high prevalence areas. So there are sometimes issues around competing priorities. GPs actually think that it's unlikely to be HIV, it's more likely to be something else. But there's also this really, really strong historical context around HIV and HIV testing. So in the 80s and 90s, HIV was a very, very different picture. But understanding and treatment has moved on so much in the last 30 years or so that it is completely different to how it was, but a lot of those kind of concerns and fears around HIV remain. So another barrier is around knowledge. So not everybody we spoke to was familiar with how many people had HIV in their local areas. So as I said, the guidelines say that people who live in an area with high numbers of people diagnosed with HIV should be tested whenever they have a blood test for any other reason. So it's really important that GPs know how many people have HIV in their area so that they know whether or not this is something that they need to be doing. A lot of people didn't feel comfortable discussing HIV, particularly with certain groups. There were certain groups, for example, older patients that particularly younger, more junior staff didn't really feel comfortable discussing or worried potentially about causing offence. A lot of the people, as I said, the lack of time is a huge issue, and people often refer to the lack of time that it would take to carry out additional testing, particularly because they were worried that offering somebody a test could then mean that they would have to start a really long, lengthy conversation with the patient about why they were being tested, why they were being offered this test, and what would happen if they actually had a positive test result. Often people who are diagnosed late don't get offered a test because they don't have any of the typical symptoms that would make healthcare providers think that a test is needed. And again, because the relatively low prevalence of HIV compared with other conditions, HIV isn't always at the forefront of people's minds. It's not the first thing that people think about when they present with potentially atypical symptoms. Stigma and misconceptions, again, coming from that widespread fear of HIV, predominantly based on the kind of the historical context and the death sentence that HIV and AIDS used to be, also a barrier to GPs offering, but also patients accepting HIV tests. And most people we spoke to had very little knowledge about PrEP, and very, very few people had had a conversation about PrEP. It was seen as something that was probably better placed in sexual health services, and didn't really accept or didn't really kind of take on board that there were certain groups that may not want to access PrEP through sexual health services. So, as I said, what we wanted to do then was to take these insights from the interviews and the literature reviews, and to go to focus groups, host lots of focus groups, and co-produce some solutions. So think about what sorts of things we can do to overcome these issues. So based on conversations, what we're currently thinking is that the intervention needs to have multiple components. It needs to include some level of education and training in some of the areas that people are currently lacking that knowledge and skill sets. We need a better way of triggering tests, so a more systematic way of helping healthcare providers identify who needs a test and when. And we need to make the whole process really, really simple, very simple, streamlined, as quick and easy as it possibly can be. So in an attempt to make things quicker and easier for people to offer and deliver tests, what we are thinking is we would like people to, or we would like practices to introduce an opt-out policy. So this approach would aim to increase testing by making it a routine part of healthcare. And there are some examples of really successful opt-out policies in other areas of healthcare. So at the moment, there's ongoing work. So opt-out policies are being introduced in some emergency departments, and there's some really, really good evidence from maternity services that opt-out approaches are both acceptable and really, really effective. And what we're planning to do is to draw on insights from these established ways of working, and we would just move it across into primary care. But it's going to look something like patients in GP practices being informed about an opt-out policy, for example, through posters. So this would mean that when a patient has a test for any other reason, a HIV test could also be added to that test unless the patient specifically declines or opts out. So at the time of testing, the patient wouldn't have to be told that they were having a test, they wouldn't have to agree to the test. But if the healthcare provider wanted to, they could say something along the lines of, we now routinely test everyone for HIV. If you prefer not to have this test, you can opt out. So this would be introduced slightly differently in different ways, depending on how many people are living with HIV in the particular areas. So in areas where lots of people have HIV, still thinking very, very, very small numbers, but relatively high. people would receive a blood test whenever they would receive a HIV test whenever they have a blood test for any reason. And in the lower prevalence areas, people would only have a HIV test if they have particular symptoms. So this is an example of a poster that could be used to inform people about the opt-out policy. This is currently one of the posters in the emergency department clinics, and we would plan to modify these to make them suitable for primary care. And this would include things like having them available in different languages, depending on the population that the primary care practice is serving, having different ways of actually communicating the material. So it could be on screens in GP practices where people can have audio if people have literacy issues. And this is an example of some of the sentences that people could be given when they are at the point of having a blood test, so when the blood is actually being taken. A couple of examples that the GP could mention the policy, just to make sure that people are aware, and they wouldn't have to say this if they believed that there was every chance that the person who they were speaking with had been able to view the communications, view the posters, and any other communications that have been used by the general practice. So the next step is to try out the intervention in a number of practices in the local area and think about whether or not it works. But there's a few questions that we're still trying to answer. So we're still struggling with what the best way will be to inform people about the opt-out policy, particularly in areas in which people there's a high percentage of the population who don't speak English or who don't read and write. We're still struggling to try and understand whether or not it's necessary for, at the time of testing, for at the time of bloods being drawn, whether or not people need to be told about it then, or whether it's sufficient to assume that people have seen the posters and possibly text messages or emails, depending on how the practice want to communicate those findings. And this is something that they're struggling with in emergency departments. Sometimes people are being told that they're having a HIV test and sometimes they're not. We are really trying to understand whether or not people would feel obliged to have a HIV test or kind of pressured to have a HIV test if an opt-out policy was introduced. And we're sure that there are other problems that we haven't yet thought about. So the more problems we can identify at this stage, the easier it's going to be for us to address those issues before we introduce it into lots of general practices. So if anybody has any comments or questions or thoughts about this research, I would love to hear them.